Hello, everybody. Welcome to Visionary Eye Doctors lecture series. We're just going to wait a couple of minutes to make sure we have enough attendees here register. And as of now, we are showing 61, and we still need to get some other, but I see a lot of familiar faces. So thank you, everyone. I am going to really quickly here be able to get back to you in a second. Okay, everybody. So I just wanted to quickly go over the order of the night and the program. I see a lot of more people logging in. Welcome, very welcome to tonight. We're very excited that you're joining us tonight because this will be Visionary Eye Doctors CE lecture. The first one actually virtually. As many of you know, I see a lot of attendees and a lot of familiar names. We actually do this 4 times a year in person, and many of you have come and gotten amazing courses over the years. But because of this new reality, well, then we are forced to do it virtually. So in advance, we apologize for any technical difficulties we might experience. But I just want to quickly go over the program. So we have a very tight schedule and a lot to accomplish. So we better get started right now. I do see right now about 70 something attendees, and we have a total of 93, but we are going to start. So I am going to be the moderator, just making sure that everybody stays on schedule. And we are going to start with Dr. Alberto Martinez, who is going to talk to all of you about updates in pterygium surgery. He should be finished about 6:20. After that, we will quickly go over questions and answers. Then we go with Dr. Allen, updates in glaucoma. Then we will also do questions and answers at the end, and that is a 1 hour certified lecture. Then we go with updates in COVID NDIs by Dr. Kremers. At the end, questions and answer. And then finally, we're wrapping up with Dr. Sureski, updates in cornea and cornea cross-linking. I will make all of them a participant. Now, for all of you, you need to know as far as questions, we will try to answer as much as we can. And the way we are going to do this is that we are actually all of you have a little question box in your GoToMeeting panels, and you can type any question that you have for any as the presenters are speaking, and I will read the questions to them. So without more introduction, I will meet Dr. Martinez, our president and owner, the presenter. Dr. Martinez, I see you there. I'm about to make you the presenter. Give me 1 second. Give me 1 minute.
Am I on? Am I on?
Yes, you are. Just make sure that you present your slides, and yes, you are the presenter.
Terrific. Okay. Hello, everyone. Welcome. I must confess, I'm a little nervous about this stuff because I'm sort of marginally competent when it comes to these things. So I hope it goes well. Welcome. We miss you guys. We have tried very hard to put together a good presentation that is useful for you, is useful for your patients, that you are going to be able to utilize this knowledge and see and be entertained and be alert. So without further ado, I wanted to just talk about my favorite subject, one of my favorite subjects in ophthalmology, which is pterygium. And so I will give you a little update. I'll be very brief. Let me get the next slide. Just a brief update on the numbers. For 2019, we did 408 pterygiums. So far this year, we're on pace, even though COVID has hit, we're on pace to keep about the same numbers. But I want you to look at the fact that there are 32 recurrences. There's a huge number of recurrences that I see, and these recurrences can come from the community. So be very careful about who you send your pterygiums to, because these are horrible situations. So these people, I'll explain to you why. We have a very specific way of doing our surgery. We have 30 years of experience on these. It's an in-office procedure, not the hospital, not the ISC, no anesthesiologist. Patients are less stressed because it's in the office. It's a casual, friendly, and professional atmosphere. And we have saved really probably millions of dollars over the years to the healthcare system. We do a sutureless procedure, and it's cautery-free. We use fibrin glue, I'll explain. We always use conjunctival autograft. It's not even debatable. And we use amniotic membrane over the conjunctival autograft for superior cosmetic outcomes. Over the years, we made a lot of improvements. Some of them have made it to the peer-reviewed literature. This was published in Cornea in 2016. And it was a very simple thing, but it was, you know, the amniotic membrane is very hard to see. It's hard to work, very thin. We just simply stain it with fluorescein. And now it's a lot easier to see. A lot of people adopting this, a very simple thing, but I think it makes a difference. One of our research fellows, Jenny Ha, found a new way to quantify the severity of pterygium that also made it to ophthalmology in ophthalmology peer review journal. One of the things that we began to do maybe a year and a half ago is to use Abatin. It's a special foam, this little foam. Most people see this amount of blood and they go freak out and they start cauterizing, which is traumatic, it's inflammatory, increases recurrence rates. We don't. We put this little foam and that just stops the bleeding. Very simple. I think the biggest improvement we've made over the last 2 years is to use, this is how most of the time, I don't know anybody who does this, when you do a beautiful graft, and we do, by the way, a large graft, we do a beautiful graft, most people leave it like that, but for us, we use amniotic membrane on top of the graft. So you can see how we have the membrane here. We cover the graft like a blanket, and it just has given us fantastic cosmetic results. As you will see, recurrence is just no longer an issue for us because, as you know, the literature shows a recurrence rate of up to 80% with Bayer sclera technique. Anybody who's doing Bayer sclera is 30 years behind in technology. That would be a shame. But we did pterygium surgery with the amniotic membrane over the donor site. We did that for a while, I'm sorry. And our recurrence rate is very low, 0.5%. We need to review the literature and look at see how often people do that. Now, you could say our follow-ups is a very variable. We have a hard time getting patients to come back. Once they look good, they feel good, they never want to come back. So it's hard keeping up recurrence rates. We have difficult problems writing papers. We can't get those follow-ups. Now, the recurrence rate of recurrent pterygium, these are tough surgeries. Some of these are high scars, excuse me, but they have a higher recurrence rate. It's still only 1.5%, but recurrent pterygium that we do have a high recurrence rate. Look at the post-operative pain rating. It's less than 1 in a scale of 1 to 10. It's amazing for this procedure done in the office. We have thousands of photograph results. These are patients, this is the same patients, it's just different lighting conditions. This is before and after. Excuse me, before and after. Before and after, we, you know, any kind of pterygium we really do very well with. How about these horrible, like, you know, nasal and temporal pterygi? We can also do that really well. It's a lot harder, it's more complex, but it can be done. We have done really lots of presentations nationally and internationally in pterygium. These are all presentations and papers that we have written. I don't want to bother you with the details. The current research initiatives, excuse me, we one of the things that I have found that is that I think the goblet cell density for pterygium surgery causes a little bit of dry eyes. It makes dry eyes worse. And one of my fears is because goblet cells that we take from the donor side to the host side, I think they come down. There's a new imaging way of doing imaging goblet cells that we're going to start using to study that. The quantification of cosmetic outcomes is really difficult. It's really hard. So we are working on ways of taking standardized photographs and sending these photographs to unbiased observers so we can have some statistics. Another thing that we have worked on is this little speculum. Excuse me, doesn't look like much, but I think it's going to make a difference. This is a prototype. Projects for the future, artificial conjunctiva, because when you remove the conjunctiva from above, excuse me, from the donor side, it is traumatic and scars. And let's say if you need a trabeculectomy in the future, it would be hard to use the conjunctiva. So creating artificial conjunctiva is one of our projects. We made some contacts with local tissue engineers. And so this is a project that is working. Another project for us is the ocular stapler. This is a stapler that we will use to staple the conjunctiva in place with dissolvable sutures, and also for intraocular. It's intraocular stapler. It's a long-term project. I want to mention pingueculectomy. For years and years, I refused to do pingueculars, but there's a lot of people that come. In fact, guys, as many guys as women, men and women, they hate these things. They hate how they look. They want that out. It just makes them feel bad, insecure. And so for a long time, I refused. But so, you know, look at since 2015, I've only done 33 pingueculectomies. It's a fraction of the numbers that I do. But we're doing more and more. And frankly, with people from all over the globe, for these, they travel for these. And we do very well. But this is probably the highest stakes surgery. This is equivalent to a clear lens exchange on a perfectly normal patient that just want to get rid of the glasses and you want to do a clear lens exchange. It's a very aggressive, high stakes surgery, but we have done beautifully, and we're going to be publishing some papers on these. Last but not least, I want to mention cornea tattoos. Maybe it's not a big thing, but it's very interesting. I thought you guys might be interested. This is a patient with a blind eye and this band keratopathy looking thing. Very unhappy about that. We scrape it with the tube knife. We scrape that and we paint it with the special pigment that I get from Spain. And then this is the needle. It's just like a regular tattoo parlor needle. You have the 1 or 2 or 3, depends how fine you want to be. And it's motorized, and then you can just essentially you drive the pigment into the stroma. You have to measure the thickness, the size, the amount of the needle that will go through, and according to pachymetry, you drive the pigment. And this is the patient 1 day post-op. We even made a little pupil. We can a little more browning here and a little more blacking here. We made a pupil. It is interesting. This is a patient who I did like 15 years ago, and I was using back then a different kind of pigment. Excuse me. This pigment, the real pigment went away. This used to be all brown, but what is left is this iron deposit. It looks ugly. The lady came from California a few weeks ago, and we tattooed her again, and she looks good. But this new pigment is really expensive, but it's lyophilized, it's micronized, and it comes from Spain, and it just really lasts essentially forever. Well, not forever, nothing's forever, but it lasts a lot longer. This case is a man who had a little trauma. There's some sutures left, and got lipid keratopathy. Lipid keratopathy is tough. I have patients who require transplants of that. We don't know how to stop it. It's hard for us to stop these little blood vessels that feed the lipid keratopathy, but we cauterize them with Avitine and other things. I cauterized, I pigmented this patient, and the patient did really well, was really happy. You can see how close this border is to the pupil. The patient was really happy, but a couple of years later, he came back, and now his lipid keratopathy has grown. This is the pigment stayed in place, but the lipid keratopathy grew almost into the pupillary axis. This was last week. I took him to the operating room, and I removed the epithelium and put ink and tattoo him. But this was so close to the visual axis. See that I was afraid to go in here and decrease his vision. So this is 1 day post-op. The guy is really happy, but that little white spot, I'm not going to go. So it's useful in some places. Patients with disfiguring cornea, glaucomas, this is a very useful procedure. Briefly, I just want to tell you that you guys have heard about Panoptics. Since Panoptics came about a year ago, we have in our practice, we have put 205 with fantastic results. Patients who've seen distance, middle, and near. Now there's a new lens that just came out. Essentially, last week I saw the first one implanted. It's called the VVT IOL, and it is this lens. It doesn't have all the rings of the multifocals, but it's this little elevation here centrally, and it is a smooth elevation, so it's a non-refractive. Remember the refractive, they resumed the old lens, there was a lot of halos and glare, or the diffractive, this symphony, and the other multifocals, people have halos, but these promises that it won't do that. And the reason is this new technology, I'm very excited about that. It's called non-diffractive X-wave technology. It's kind of patented and secret, and Alcom won't tell us about that. But I thought this was an interesting slide because it shows the Acrisoft lenses. The Acrisoft lenses, monofocal gives you all these range, but it stops at about 66. So you don't have, with the monofocal distance, you don't get middle distance or near distance. The Symphony was a great lens, but it also caused a lot of glare and halos. We move on to the Panoptics, and the Panoptics has been fantastic because the patients have been really happy with their near range. Look at the near range, 16 inches. Patients are very happy. And these VVT promises to be a lens that is going to give you an entire range, although not as close. So it's going to be for distance and middle distance. I'm excited. I will let you guys know how it goes. So that was that. That was my presentation. Thank you very much. If you have any questions, let me know. This is my number, cellular number. If you ever have any emergency, anything, anytime, I live very close to the office. Please call me. You know, I'm there. It's not just me, but my whole team is there for you, so that you can either call me or you can email me anytime about anything related to your profession. We're here to support you. We are a team. We want your patients. We want to give you support. We want to give you patients the greatest care they can get, but also you as an individual, if you have any questions, please let me know. Thank you very
Thank you,
much.
Dr. Martinez, for a wonderful presentation. You are just in time. I do not see any questions here for you, but I will continue to make Dr. Allen the presenter. And Dr. Allen is going to start with updates. Hello, Dr. Allen. Haven't seen you in ages.
Thank you, thank you.
Okay, we're ready for you.
Yes, so welcome everyone. Let me go and
Oh, Dr. Allen, as far as time, you do have between 35 to 40 minutes, okay?
All right. Okay. Now, you seeing my first slide?
Perfect.
And welcome everybody. And in person right now, which is kind of bizarre for me because I like to see the faces. I like agonists like brimonidine, apraclonidine, epinephrine, and prostaglandin analog, and the new kids on the block, which is the rho kinase ROCK inhibitors, and talked about combined medication and a little bit on hyperosmotic agent, because you're not using that, but you're all familiar with the other ones. I will begin with adrenergic agonists because it's a little bit more difficult for people to be familiar with this, because we don't those are not the main line of treatment. We use it as an adjuvant. We have a non-selective agonist, which is epinephrine and bipinephrine, and the selective ones are apraclonidine and brimonidine. The goal of those is to lower the intraocular pressure. We use them on open-angle glaucoma and ocular hypertension. We also use that on prophylactic for post-op increased pressure. When you leave some viscoelastic, we can use that to release the pressure without having to burp the patient. And also we use that before and after laser treatment, for example, trabeculoplasty, or before LPIs, to lower the pressure before the surgery. And we use sometimes after cataract surgery, and with also on acute angle closure glaucoma. And we also use it off-label for little miotic after refractive surgery to avoid glare at nighttime. What are the contraindications for those drugs? For the non-selective one, when we have narrow angle because of some dilation for the non-selective one, that may precipitate a pupillary block. We also have to be very careful on patients that have a planned blepharoptosis surgery. You should not use those drugs because they stimulate Mueller muscle and mimic some correction of the ptosis, that when the drug is stopped, the surgery will be undercorrected, which will be an inadequate correction of the ptosis. When you plan to do retrobulbar anesthesia, which we for anterior segment surgeon, we no longer use that except on some circumstances when we're planning trabeculectomies, but this is mainly used by retina surgeons. We have to be careful when you use brimonidine for that, because there is of vasospasm and occlusion of the central retinal artery with that drug. We can also have some systemic effect like tachycardia and even death on some individuals. Using brimonidine on aphakic, there is an increased risk of CME that between 13 and 30%. Those are, if we have some sensitivity to the agent, we don't use those drugs. And on people concomitantly on monoamine oxidase inhibitors, we should not use brimonidine, as well as on infant and children younger than 2 years old. We should not use because there's reported apnea and bradycardia on some kids. And for the pediatric age between 2 and 7, that has been reported some cases of convulsion, hypoventilation, lethargia, and the drug is relatively contraindicated. The caution we take for us also, we don't use that on severely compromised cardiovascular patient. Patient with depression, we should avoid those drugs. Cerebral palsy, coronary insufficiency, Raynaud's disease, we should avoid that. People that have orthostatic hypotension, we should avoid that. And pregnancy, it's a drug that's classified as a category B, and there's a potential risk for the fetal tissue. What is the mode of action of the adrenergic agonist? For the non-selective alpha and beta adrenergic agonist, over time, they lower the pressure. The reduction of pressure seems to last 12 to 24 hours. That's why those drugs are used usually twice a day and sometimes 3 times a day. For the selective alpha agonist, it's one of the addition is decreased production of the aqueous humor. That there was in the past some controversial neuroprotective effect of brimonidine that has not panned out to be true, but still the manufacturer is putting that as one of the potential side effects to protect ganglion cells. Complication of therapy, we have local injection, follicular conjunctivitis, and mydriasis, stinging, blurry vision, and headaches. Some cardiovascular, we mentioned that earlier, tachycardia, arrhythmia. For the selective ones, which is the brimonidine is included in that group, local hyperemia, follicular conjunctivitis, some conjunctival bleaching, but it usually doesn't last. And the systemic effect, we have dry mouth, fatigue, anxiety, and respiratory depression in neonates. What are the contraindications? I mentioned that earlier. If you have a narrow angle, the adrenergic agonist may precipitate pupillary block. And again, I mentioned that earlier. Blepharoptosis surgery, we have to be careful in using that. We all mentioned that the mode of action is to lower the pressure, and we mentioned that already. Complication, we mentioned that. Those are the side effects we may have on patient, and that's on patient that had severe allergic reaction to brimonidine, that you can see dermatitis and swelling, and this is, you have to stop the medication. And this is less severe, but you can see there is a lot of crusting, a lot of tightening of the skin around the eyes, and some ptosis. Those are signs of allergies. And that is a classical sign of allergic with follicular conjunctivitis with brimonidine. And we switch to now beta blockers, which is the leading agent that we use is timolol. We usually use it at 0.5%, but some people on more sensitive patient, there is an available dose of 0.25%. The timolol is what we use, but there is also existing on the market levobunolol. Carteolol is less used right now. I'm not hearing that. And for the selective beta blocker, betaxolol also exists in the market and are still being used. Indication, it's one of the first line of treatment for ocular hypertension and all type of glaucoma. Although nowadays, probably most physicians, because of the side effect of the beta blockers, tend to switch to the to latanoprost, which is a drug that we use in first line, and we use the timolol as a second line if there is no contraindication to use it. And we sometimes use it after cataract surgery, after laser surgery, to decrease the pressure. Contraindication, or if we have sensitivity to the agent, or if we have any, we usually recommend punctal occlusion with the timolol. And if we have a patient that has a hard block greater than first degree block, it's a contraindication to use beta blockers. Relative contraindication is congestive heart failure, although I've used timolol on congestive heart failure, but you have to recommend the patient to be careful and to do punctal occlusion to minimize the absorption. Or if the patient has already have bradycardia, we usually try to avoid the beta blockers. The mode of action is on the ciliary processes, that we have reduction on aqueous humor production is a direct action, and also it's a direct action on also the non-pigmented ciliary epithelium and decrease the secretion. Also decreases local capillary perfusion that reduces the production of aqueous humor. Administration, it has a good corneal penetration. The peak aqueous concentration within 1 to 2 hours when we check that in the anterior chamber, and the effect peaks at 2 hours and lasts several hours, usually about 12 to 18 hours. Short-term escape, we sometimes have a dramatic reduction of the pressure at the initial and small rise with plateau within a few days. That's why we usually, when we test those drugs, we usually give a patient out a trial and we see them in a few weeks to see what is the final effect. In approximately a month at the procedure, we can see, and sometimes the patient drift back to, and we have less effect. And after 3 months, we reassess again, and we may have a decrease of the effect, but you usually stay pretty effective. And in some patients, because of to regain some responsiveness, we give them a drug holiday and we restart. Efficacy, we have 20 to 30% reduction of the IOP. On the selective one, which is the betaxolol, we have only a 14 to 17% of IOP reduction. There is a decreased efficacy when we use oral beta blockers concomitantly with those drugs. There is a small decrease of the effect. The systemic absorption of those drugs, we can have a contralateral IOP lowering on the other eye. Complications, we have ocular toxicity, burning, hyperemia, corneal anesthesia, punctate keratopathy, erosion, keratopathy, periocular contact dermatitis, dry eyes. But usually those periocular dermatitis are usually from the preservative on the drugs. I've not seen timolol itself. It's rare for timolol itself to cause the dermatitis, but that can happen. And the cardiovascular effect, there's a beta-1 blockage, slowing of the heart rate, and patient can experience fatigue, arrhythmias. They decrease exercise tolerance because their heart rate cannot go that high because it's blocked by the beta blockers. On those patients, we try to avoid or to tell them to time their instillation of the timolol with their exercise and use the beta blockers after they finish exercising. And the beta-2 blockage produce a contraction also on bronchial for people with asthma. There's a relative contraindication with people with asthma because the beta blockers can cause bronchospasm. And that's why I don't use it on asthmatic. On when patient have his history of asthma, I have other choice. I don't use the timolol. And the central nervous system, we have some effect. There's depression, anxiety, confusion, hallucination. All of those have been reported. But the main thing that usually men are interested in is there is decrease of libido that we try to avoid the beta blockers because of that on some individuals. The effect with cholesterol level have been noticed with the alteration of plasma lipid profile. This is something that would not necessarily be a contraindication, but if we already have a problem with high lipidemia on some patient, we try to avoid beta blockers. Exacerbation of myasthenia gravis, someone with myasthenia gravis, it's relative contraindication, not, we don't use beta blockers. May mask on diabetic, some awareness with hypoglycemia, because it's important for the patient to know when their blood sugar is down. And if you put them on timolol or on any systemic beta blockers, they will have a decreased sensation and they won't really know when they're hypoglycemic. And we should caution them of that effect if those drugs have to be used. And they may have GI distress. And as I said, beside the libido, sexual impotence on some, one of the side effects of the beta blockers. To prevent the complication, we should avoid the beta blockers on high-risk individual, do nasolacrimal occlusion, use the beta blocker maybe on a selective one like the betaxolol, but we have to accept there's also less effect on the lowering of pressure, between 20 and 30 for the non-selective and 17% reduction on the selective. There is a decreased incidence of respiratory effect with the betaxolol. There is the carteolol is a drug that could be a replacement because there is some adrenergic agonist effect with the carteolol, but it also has less effect on the plasma lipid profile. Management of the complication, we just discontinue the drugs. And if we have to use the drugs for whatever the reason, we have to warn the patient, we have to ask them to take all precaution to do punctal occlusion to minimize the absorption. And we switch to carbonic anhydrase inhibitors, which is the Dimox is a commercial name, acetazolamide. In systemic there is 3 different dosage depending on the weight of the patient that you want to use it for, and metazolamide, which is usually well tolerated. It's a stronger molecule with less dosage, you can achieve the same effect. The 2 topical carbonic anhydrase inhibitor that we have available in the market is dorzolamide and brenzolamide. And sometimes we use them by themselves or in combination with timolol. And the indication is to reduce the intraocular pressure. We use them as monotherapy or additive therapy, usually as an additive therapy. We sometimes use them as prophylactic when we have to do surgery or around the time of surgery and can reduce acutely the intraocular pressure. The contraindication is if someone has a sulfa allergy, we usually try to be cautious and not use the carbonic anhydrase inhibitors. And I've seen kidney stones. Plastic anemia is rare, but we have to make sure that we have studies for the patient prior to put them on systemic carbonic anhydrase inhibitor, mostly when it's a long-term intervention. Thrombocytopenia, and on sickle cell patient, we have to be very careful. If the patient has a history of blood dyscrasia, we usually avoid that type of drugs. Mode of action, it blocks the production of aqueous humor. You have to block 90% of the glands to achieve some of pressure reduction. Potential side effects on ocular blood barrier, those have been established in some patients. Complications for the carbonic anhydrase inhibitor: there is a burning, stinging sensation, metallic taste that the patient report after using that because it goes to their throat. We have to be cautious again if we have kidney stones or sulfur allergy. Corneal toxicity has been reported. Paresthesia, Stevens-Johnson syndrome, same reaction we have when it's the same reaction that we have on sulfur drugs in general. And blood dyscrasia, the same thing. Sickle cell, we have to be very cautious. And we've noticed on some patients hypokalemia that we can fight by asking the patient to take supplement of potassium, eat bananas, and that's one of the way to counteract the hypokalemic effect. Conjunctival injection and periocular contact dermatitis, same thing with any drug we use. Most of the time is the preservative, not really the drug that causes the contact dermatitis. And this is one of the picture of, you can see hypopigmented on his back, and now you can see hyperemia on the skin and petechia on the skin, and those are the side effects of the carbonic anhydrase inhibitor with the systemic absorption. And this is same thing, some dermatologic petechia on the right, and scaling and dermatitis on the left. And those are what we see on some patients with corneal edema. Usually those are cornea already compromised after surgery that have the endothelium not working well. The carbonic anhydrase inhibitor just precipitate them into trouble. And we have to monitor the blood potassium, mainly when we use them systemically. When you use them topically, we may not need to do that. And on patients systemically, and we have to put them on medication systemic, we have to consider pre-treatment blood count, and we avoid the topical ones on patients that have marginal endothelium, like I said before. And if they have history of sulfur allergy or blood dyscrasia or kidney stone, we don't use them. Management of complications, like any other medication, we stop it. For the topical medication, we can try to switch. As I said, switch from acetazolamide, which is a larger dose that we have to use, to metazolamide, which is a smaller dose, and it's usually better tolerated. If we have to do some consultation with their primary care physician, if they have a potential for serious side effect, and we can switch to a slow release acetazolamide, which is the 500 sequel of Dimarx that has been well tolerated on some patients because they don't absorb the whole 500 at one time, but we have some over time they absorb the 500 little by little. On the combined medication, I put it there because we already talked about timolol, we talked about brisolamide, and we talked about the acetazolamide. We have existing on the market in the US a combination of dosalamide and timolol, which is COSA. To obey the rules, I removed all the commercial names, but I'm just going to name them. The brinzolamide, brimonidine, exists also on the market, made by Alcon. The timolol brimonidine also exists on the market by Allergan. It's called Combigan. And the latanoprost, brimonidine, and timolol doesn't exist in the US, but we see it sometimes when patients traveling and bringing those from Latin America. Indication is to lower the intraocular pressure when one drug is not sufficient, because we know every time you add a second bottle, you decrease the compliant with the patient. We try to reduce the number of drops during the day, and we have a better chance to control them. Patients have difficulty taking multiple drops because some of them don't have good coordination. They shake, they lose the drop, and it's better to try to combine them to give them one drop. And the dorzolamide and the timolol exist on the market today. Actually, they exist on generic form, and it includes the non-selective beta blocker, which is timolol, and dorzolamide at 2%. And it's usually well tolerated, except if you have one patient that reacts. Sometimes you don't know which of the drugs the patient is allergic to. You have to remove them and restart them one by one to see which one they're allergic to. You cannot basically give up on timolol and dorzolamide at the same time because of the allergy. You have to try to identify which one is creating the allergy. But if it's a systemic side effect that we have, we can encourage nasolacrimal obstruction, emphasis on the correct dosage, because talking about dosage, I had an experience with one patient that needed intervention with beta blockers and mainly beta blockers after surgery because the pressure was high. But because he bought a generic bottle with no color coded, he was confused because he also was on prednisolone. He was using prednisolone and timolol, and he was to use the prednisolone at 6 times a day and the timolol twice a day. And guess what? He confused the bottles, used the timolol 6 times a day, and he ended up to the emergency room with severe bradycardia. So you have to make sure they can read the label and encourage the patient to buy a bottle that is color cap coded, which is the beta blockers on yellow cap, and the steroid is usually on a pink cap. But on the generic drugs nowadays, it's difficult to force those manufacturers to observe those rules, and they deliver those drugs on all white caps both ways, and it's difficult for the patient to read the label. And those are what we see when we use combination, that it's patient is on 3 drugs, and it's difficult to know which one of them, and we basically have to stop everything and restart them one by one and identify the culprit. And I'm going to go over the hyperosmotic agent quickly. I'm going to skip that because I don't think you as a provider will use those drugs. I just mentioned that because we use them sometimes during surgery or in acute situation where we have an acute angle closure glaucoma to shrink the vitreous to lower the pressure that way. But it's rarely used on a clinical basis. It's usually when you use them around the time of surgery. I'm going to skip that. And we're going to go directly to pilocarpine type drugs, which is parasympatomimetic agent, which is the 3 that exist on the market is carbachol, pilocarpine, and ecotropic. But the one we use usually on the clinical basis and a regular basis is pilocarpine. As a surgeon, you can use carbachol sometimes at time of surgery to constrict the pupil, but the pilocarpine is the one that is still being used clinically on patients to control glaucoma on some individuals, but it's getting rarer and rarer to see patients on pilocarpine. We still use it on acute angle closure glaucoma, and to prepare the patient for LPIs, we still use the pilocarpine. Contraindication: if we have a patient that has no trabecular outflow, the pilocarpine or the parasympatomimetic agent will not increase the outflow. You will have the side effect without any effect. And there's a potential on patient having peripheral retinal diseases to get some traction on the vitreous base and have some tears and lead to retinal detachment. On uveitic glaucoma, you exacerbate the problem by creating a lot of contraction on the ciliary body. Usually on uveitic glaucoma, we have a tendency to relax the ciliary body to eliminate the pain. And if you add pilocarpine, you're just worsening your problem with the inflammation. On acute infectious conjunctivitis, it's not recommended. And when we have a sensitivity to one of the agents, of course, we don't use them. And on chronic, if we have chronic changes on the lens, the pilocarpine may precipitate cataract formation. Mode of action is the contraction of the ciliary muscle pulls the scleral spur, tighten, and open the trabecular meshwork that increases the outflow. That's there is a direct action on the motor plates by the way of acetylcholine to basically constrict the ciliary body. And there is an indirect action. It's a prolonged action that we have to the parasympathetic dominating agent. It's usually with the carbachol. What are the complications of the pilocarpine type drugs? It's more frequent. We have an induced myopia because they basically constrict the ciliary muscles, inducing myopia, brow ache, conjunctival and intraocular vascular congestion. We have cataract formation, as I mentioned before, and we can have precipitate a paradoxical angle closure because we increase the surface of the irido lenticular surface is increased, and we can cause a pupillary block on some patient. And we can also cause posterior synechia by prolonged contact between the iris and the lens. And in some patient has been reported corneal toxicity and periocular dermatitis, like any other drugs possible. And this is one of the sembliferon that you see on the bottom part of your picture between the lower eyelid and the conjunctiva. Is by chronic use of pilocarpine. And iris cysts have been reported also developing with those agents. Lacrimal stenosis, which is the punctal, you have punctal stenosis, and pseudopemphigoid reaction of the conjunctiva has also been seen. If the patient has uveitis, you can have a lot of fibrin in the anterior chamber that we call it fibrinous iritis, especially on post-op that you have to use pilocarpine. I'm not sure why, but sometimes we use the pilocarpine to constrict the pupil or the carbachol to constrict the pupil, and we can have that effect in the anterior chamber the day after surgery. On retinal detachment, we don't use the pilocarpine because otherwise you won't be able to see the retina, and complication can be minimized by titrating dose. On blue eyes, you can use lower dosage. On high pigmented eye, you will go to a higher concentration at 5%, at 4%, I'm sorry. Compliance is usually a problem because of the side effect we have with pilocarpine. That's why it's not a drug that we use chronically. And this is an illustration on the type of iris pigment that you can have. The cyst, epithelial cyst, that's what we can see in the pupillary margin. And it's a big one on the upper picture, and after lasering that cyst on the lower picture, we can get rid of it. The prostaglandin analog have been there for years, and they usually now, I think, took the first line of intervention because of convenient. It's a one-time drug medication, once a day drug medication with very, very little and no systemic effect. That's why they've now been used as a first line intervention. And most patients, when we start them on medication for glaucoma, it's with the prostaglandin analog, latanoprost being the one listed on the market the longest. Xalatan, that's the one that has opened the floodgate for those drugs. Has been reported when you have uveitis or iritis, it's a drug that we should not use because it's prostaglandin, as you know, is a precursor for inflammatory agent inside the eye, and we should avoid them. On macular edema, we also should avoid them. Relative contraindication on aphakic or pseudophakic that with open posterior capsule, they sometimes can cause macular edema. And recent intraocular pressure, that's why some physicians, when they do cataract surgery for patients with glaucoma medication, tend to stop the prostaglandin analog for at least a week around the time of surgery to restart it after. When someone has a history of herpetic keratitis, you can exacerbate and cause some recurrence of the herpetic keratitis. And when you have previous CME on some patient, they also should be avoided. The mode of action and the 4 drugs we have on the market is latanoprost, travoprost, bimatoprost, which is the latanoprost is xalotane as a brand name, travoprost is travatan, and Lumigan is the bimatoprost, and Rescula is a prodrug. Increase the uveal outflow and some trabecular meshwork outflow, but mainly uveal outflow. Maximum pressure reduction happened in about 12 hours, but a maximum about 24 hours. It takes about 3 to 4 weeks to get the maximum effect. That's why you use it once a day, and using it twice a day doesn't usually, it's not recommended. Complication, we have darkening of the iris on some individual, and the periocular skin, mostly on people that non-Caucasian, which could be a problem because they look like a raccoon when it's everything is said and done, and the patient, we have to talk to the patient before putting them on those drugs because they increase the number of melanocytes around on the skin, and it's permanent, which means you have to tell them that is a potential effect, and if they don't want that effect, you don't use the drug. And if someone has uveitis, we don't use that either, or you try to stop it around the time of the activity of the uveitis. But if the pressure is really high and the nerve is compromised, this is a relative contraindication. It's not a hard stop contraindication. And this is an illustration of the prostaglandin analog changes in pigmentation. The right side eye, it shows you the hyperpigmentation on an eye with latanoprost compared to what the iris was before intervention. And this is an illustration of a pseudodendrite that we can see appearing on the right side of the slide. And to finish with the drugs available on the market, we have the Rho kinase, which is natausidil 0.02%, which inhibits the Rho kinase. It's a Rho kinase inhibitor that also increases the uveal outflow and also the trabecular outflow. By itself, we usually have about 4 millimeter of mercury reduction of the pressure. And in combination with latanoprost, we have a little bit more. We're talking about 25% reduction of the intraocular pressure when you combine the latanoprost and the natausidil. And this is a slide to illustrate that. And we also have available, we cannot say it's perfectly medical, it's partly surgical because we can inject a pellet of bimatoprost inside the anterior chamber to give us a 6 months continuous release of the prostaglandin analog inside the eye. For someone that doesn't have any contraindication, that is kind of non-compliant, it's one option we have, and that can be done in the office. And we have about 33 reduction pressure when from baseline, same thing as the drug itself, used once a day, but we have a good 6 months with the pellet inside the eye that can be done in the office. And that is also available with the armamentarium that we have to fight that dreadful disease. I will not finish without talking about some exotic drug that doesn't exist in the market in the US, but has been on the market for more than 30 years now. We're talking about extract of cannabis sativa that is not fabricated here, but in Jamaica, for example, there is a manufacturer that fabricates cannasol, which is an extract of the cannabinoid. And I've used it in the past because it was available outside of the US and in Canada for a while. And we had a good 20% reduction of IOP, because you have to know if you take marijuana, which is the cannabis, you will have to be 24 hours stoned to get the effect. If we could just use the drug in the eye, we have the effect without the side effect. And I have a few patients that are buying it online and they have a good result with no side effect. I'm not sure why in the US they never studied that to make it available on drops form for patients, because that would be a life changer for some patients, because the more drugs we can find to control that pressure, less we're going to go to surgery, because surgery, no matter how you cut it, we have a 40% rate of failure on any kind of surgery you do for glaucoma. And that's why I wanted to give you an update on the drugs we use before going into surgery. But surgery, most of the time on patients that have no money, no means to sustain themselves in terms of buying the drugs, that's the only way to resolve the problem is surgery still. Thank you for your attention. And I switch to Carolina. If we have any questions, I will be happy to answer those questions.
Thank you, Dr. Allen. Let me go ahead and see if you have any questions. And no, you do not have any questions. Thank you so much for a wonderful presentation, Dr. Allen. I'm going to go ahead and give the control to Dr. Kremers. Thank you.
Thank you.
Hello, Dr. Kremers. Dr. Kremers, we cannot hear you.
You hear me now?
Very good. Yeah, we hear you. I'm getting out. Thank you.
Okay, let me just get everything ready. Okay, thank you everybody for being here. Carolina, just text me or let me know if you can't hear me. But thank you for sticking with this wonderful CE program. Everybody should know that, I think a lot of practices and many of your practices obviously have been very much affected by COVID. I think, remained open every single week. We saw our post-ops, we saw our patients, so we did a good job of trying to keep this under good control. So, thanks to Carolina and the team, of course, to do that. So I'm going to talk today about COVID, the eye, and the ocular surface. And this is really a hot topic, as many of you know. My blog is listed here, my cell phone, my email. If you have any questions, of course, let me know. And thank you to some of you for sending me a text to say you saw me on NBC. Some of you mentioned that it must have been an important issue because they put me on election night. So it's hard to believe, but a week ago was election night, and they ran this piece where they wanted me to talk about face masks and dry eyes and the effect of dry eyes on COVID. So we're going to talk a little bit about that and share this with your patients, because a lot of patients, as all of us know, are starting to notice their eyes more and more. So the purpose really today is to talk about COVID's chance of entering through the eye, to discuss the signs and the symptoms of COVID-19 as regards to the eye, and to discuss whether dry eye disease is a risk factor for getting COVID-19 entering through the eye. So as many of you know, one of the first people to talk about COVID was Dr. Li, a Chinese ophthalmologist who was treating a glaucoma patient and contracted COVID-19, probably at the slit lamp or something like that. He must have touched his eyes or face or something. So he died February 7th and tried to warn the medical community about COVID, but many didn't listen to him. So that he's kind of shut down. So this is kind of to honor him as well. And many of you know that COVID-19 is the name of the actual disease. The SARS-CoV-2 is the name of the virus. That's why those two words are used. But we're familiar with coronaviruses. In the many common colds are coronaviruses. But this is a particular type of virus where the protein on the outside of the virus is new to humans. And that's why many people have been kind of having a really tough time with it. Some people do well, some people don't. And there's a lot of different factors people are trying to understand why. So coronaviruses are also like SARS, severe acute respiratory syndrome, and then MERS, the Middle East respiratory syndrome. And coronavirus, as we all now know, it was was first found in the Hubei province in China. So can COVID enter through the eye? The answer is yes, it can. The conjunctiva has these specific ACE2 receptors on its surface, so the coronavirus can attach to those cells and gain entry into the conjunctiva and into the bloodstream. The risk is unclear, and one of these famous ophthalmologists at Stanford Medical School, Dr. Manch, mentioned that it's probably the least common mode of transmission. The number one mode of transmission is through the nose. And if any of you have not seen my protocol, which many of my colleagues and friends and family have been using on how to prevent COVID's entry into the respiratory tract and lungs, I highly recommend you just go to my blog and look up COVID, and you'll see the whole protocol. I've done videos on YouTube about this, but it really works. So what you're trying to do is stop COVID when it gets into your nose, which is the number one place it enters. Try to stop it from getting into your lungs and bloodstream and then leading to a cytokine storm. So you're trying to decrease the viral load. And the way we do that, there's many ways. The way I do it is either I'll use 70% alcohol and clean out my nose, or use diluted betadine. 5% is more than enough diluted. You can use very salty water. You can use Listerine. You know, what you're trying to do is just coat the respiratory tract as it goes to the back of your throat to prevent the virus from getting into your lungs. So there's now papers on this that have shown this works. Many of you know that we use betadine 5% before any eye surgery, and it's very safe. So getting it on the mucous membranes, whether it's betadine or hypertonic saline, is very safe. So this is something that does work to decrease its entry into your bloodstream. So I have to put in a plug for that to just warn people about it. And then there was a recent paper about whether wearing eyeglasses decreases your COVID risk. And the answer is probably yes. We need more proof. There were 276 patients in this study, and it showed that there was significantly decreased number of COVID patient cases in patients that wore glasses. So it's a small sample size, but of course the physical barrier, whether you're wearing a mask or glasses, probably does protect us a little bit more from COVID. So the signs and symptoms, these are patients that are coming to see us with what looks like just regular either conjunctivitis or dry eye symptoms. A recent study of 56 patients showed that 15 or 27% had ocular symptoms such as conjunctivitis, sore eyes, itching, foreign body sensation, tearing, redness, dry eye secretions. So a lot of these patients, well, 11% in this case, had ocular symptoms before the respiratory symptoms, up to even a week and a half before. So we know that we might be seeing COVID patients that are coming to our office with conjunctivitis, suspicion for EKC, dry eye symptoms, who are manifesting themselves with their first symptoms as a problem with the eye, even before they have a fever, even before they have any other cough or anything like that. So we have to be on our guard to prevent ourselves from getting COVID. And so, as I mentioned, if I feel like I've been exposed to COVID-19, or I start to have any of the symptoms of a runny nose, stuffy nose, sore throat, cough, headache, I start my protocol. And I really do think it works, and we're waiting for the randomized controlled studies on that. So this basic paper did show that many of these patients did have the symptoms of conjunctivitis or eye symptoms before the actual positive COVID systemic symptoms. So even though the conjunctivitis is rare in COVID, it does present that way in some patients. So I want to just show a couple of cases here that have been published. The first one was a patient that was published, and it was in a Canadian journal, a 29-year-old patient who presented from the Philippines with rhinorrhea, so runny nose, cough, nasal congestion, and conjunctivitis. And when they took a look at the cornea, they thought there was a herpetic dendrite, and I'll show you what that kind of looked like. So they started valcyclovir and then started the other medications trying to prevent a viral, herpes viral infection. But the conjunctival irritation and pain and redness worsened, and the vision started to decrease. So then they finally did the swab test for COVID, and it was positive. And so let me just show you. This is a schematic from the paper that was published in the Canadian Journal of Ophthalmology in 2020. And you can see here on the left how it initially presented with a little bit of small epithelial infiltrates with an overlying epidefect, some follicles, some conjunctival injection, and then they thought there was a pseudodendrite in the kind of right-hand corner at 7 o'clock, and that's why they thought it was herpes. And then it just got worse. So that is what happened with this particular patient. I just want to just kind of go through and show you here. You can see that there. And okay, so it just eventually just took over the whole cornea. And then here, let me just go on to the next slide. As the imaging fluorescein stain reveals the conjunctivitis of the right eye, you can kind of see the staining there. The conjunctiva was very injected, very watery. This is what the patient looked like on the second visit on March 5th. This is a second case report that was reported in Ophthalmology Times of a 48-year-old COVID positive female who presented with mild conjunctival injection of the left eye. And after the 4 days, her eye showed minimal improvement, and there was pain and foreign body sensation. And so this kind of could look like a regular adenovirus. It could be technically dry eye. It's hard to tell. This was a telemedicine consult. And it wasn't until she was tested that they found out it was really probably from COVID. So those are some examples of how they can present. The question then becomes, of course, for many of our patients, is dry eye disease or ocular surface disease a risk factor for COVID entry? And the answer is probably yes. It makes sense that it does. We know that dry eye is a chronic sub-inflammatory reaction on the ocular surface. There's an accumulation of these molecules, the stagnant tear film with these extra inflammatory molecules, decreased levels of mucin, lead to the destruction of the tight junctions, which is what you are seeing when you see superficial punctate keratitis or staining on the cornea, is that the tight junctions have just been destroyed and the fluorescein is starting to get into the deeper Bowman's layer. So that's what's happening. And so therefore it makes sense that a bacteria or virus could get into the cornea or conjunctiva in that mechanism, and it probably does. The issue is that it's very hard to prove this. So we do know that there's an immune system that's trying to attack the foreign body of the virus or the bacteria. There's an innate response as a first line of defense against infection, such as the mucous membranes, the conjunctiva, the secreted proteins like lysozyme in your tears, the mechanical barriers of closing your eyelids. So those are key components, as well as the adaptive immunity. Once you get attacked with the virus, your immune system will then react if it hits it again. So those are the key components with this. So yes, it probably is a risk factor, but there's actually very little evidence in the literature to prove it. So that's why it's controversial. We do know that autoimmune diseases are a risk factor for corneal infections, probably also for COVID, which has been playing out in the data in terms of deaths from COVID. Contact lens is a risk factor for corneal infections, but we don't have really good data to say contact lens use increases your risk of COVID-19. But of course, if you touch your contaminated hands to your eye, then theoretically that could happen. So everybody knows that dry eye disease is a multi-billion-dollar problem. We have more than 16 million people in America that do have dry eye. And if even just a fraction of these patients have a slight increased risk of COVID, which is probably true, we're talking about thousands of patients that could get COVID from their eye. So obviously we want to control the dry eye situation. Many of you have seen my checklist that we use in the office, things that kind of go through. This is all on my blog. Things we go through of different treatment options. It's a lot of information. People, of course, get overwhelmed, but this is kind of just to give you that idea of how we treat our dry eye patients, and we have been treating them incredibly successfully. So we've had now patients, even through many shutdowns, people have been coming in to see us. One of my patients is a well-known journalist in the area, and he came in 2 weeks ago and he said, wow, this is so weird. I can't believe I'm here. I said, why? He's like, well, I haven't been out of my apartment in 6 months. And I said, what? He's like, no, I haven't been out of my apartment. I had to come see you because my eyes were killing me. So people are coming out to see us as ophthalmologists and optometrists because they're really miserable. And they're, of course, scared of COVID, but they can't take it anymore because they're on the screens, they're not blinking, their tear film is drying out. It can be one of the most painful things you can have is dry eye pain, as we all know. So we try to give this information of all the treatments to kind of indicate where they are in the treatment protocol and what we can do. So we've had a lot of good success with trying to get rid of dry eye symptoms and helping with signs. Okay, so as the NBC piece was asking, does mask wearing really increase dry eye? Likely, yes. You have the breathing of the air kind of continuously hitting your eyes. So if any patient has dry eyes, I do tell them to kind of put a piece of tape or pinch the wire down or make sure there is a wire on their mask. But the real reason for the increased dry eye that many of us are seeing especially in children, is probably the increased screen time. So they both go together. So obviously we're having a lot of teachers come in. I've had more people complaining of styes in the last few months than I probably have had in my entire career in terms of friends, family, patients, colleagues. It's shocking. And of course, it's probably because we're all on screens more. So it's still very important now more than ever to recommend the blinking exercises, closing your eyes, looking away, the warm compresses. I've become a big proponent of blue light filtered glasses, which I have my own theory of why I think it's needed. Not just the macula, but I'm very concerned about our Caucasian patients and the blood vessels being maybe absorbing more blue light and leading to more inflammation. So I think blue light filters are a good way to go for our patients. So basically, we just recommend, like the NBC piece noted, trying to, of course, do anything you can to prevent the air from coming and hitting your eye, taking breaks, trying to not spend so much time in really hot environments, or too much AC, too much, dry heat. Don't let the AC or the heat of the car hit you right in the eye. And then just be very careful if you are on the screen extensively, which, according to the literature, believe it or not, the best paper out there was a New England Journal of Medicine paper that said more than 4 hours of screen time is excessive. That sounds ridiculous, but that's the best paper there is to date as to what excessive screen time really means. So obviously all of us are on screen time more than 4 hours a day, so we all are at risk. And I recommend every single one of you and all your family members and all your friends and those you care about to get a myography every year. That's what I do for my family. That's what I do for myself. I do mine actually twice a year, but it's something you want to know. You want to know your prognosis. You want to know your kid's prognosis. You want to follow it over time, because you do not want to be in a situation when you're 60 years old and you do not have glands, because it is very difficult to regrow those glands. So myography every year, totally worth it. And something that highly recommend. So the question is, what is the new normal, and is this the new normal? This was in a recent paper by an ophthalmologist recommending and actually sending to his patients lissamine green. So the patient during a telemedicine consult could put the lissamine green in their eye, and then he could take a look and see how much dryness there is. So we might need to think outside the box. There are patients that I telemedicine with every week around the world and even locally that are scared to come in. They don't want to get COVID, but they're miserable. How do we assess them? We may need to do this. We may need to charge a little bit to send them a strip of fluorescein or lissamine green so we can better look at them on telemedicine consult, because it's something that people are really concerned about. They are noticing their eyes, and it's going to get worse because we are all on screens, and it doesn't look like it's going to let up anytime soon. So thank you for your attention. Please check out my blog. I have a lot of videos. Please subscribe to my YouTube channel. We're trying to make this more user-friendly in terms of videos. So if there's any ideas you want in terms of a video, please let me know. I'm happy to help with that and help your patients understand. We have a lot of dry eye videos. We have a lot of videos on cataract surgery, pterygium, glaucoma, narrow angle, just how to do blinking exercises, how to use tea tree oil. So check out that for your patients. And this is my cell and my email. Feel free to text me or email me. And thank you all for being here.
Thank you so much, Dr. Kremers. Wonderful presentation as always.
Thank you.
I don't have any questions for you, so I just want to I want to answer a couple of questions. People are asking me, how are we monitoring the attendance? So these, in order to provide the credits, well, we do have everybody here that attended, but we do have people that seem inactive for more than, I don't know, 15, 20, 30 minutes. And it is okay. I mean, I understand it's hard to stay there all the time. You might need to go and grab something to eat or go to the restroom, but that's how we are monitoring, just seeing here that everybody is attending, and that if they need to step out, it's really not for a lot of time. Okay, now I am going to continue with, another thing I wanted to say is, everybody is seeing the slides. We are all seeing them. A couple of people don't see them, but I think it has to do with their computer. But I do want you to know that tomorrow we will be sending a survey, and we will also be sending the slides through SlideShare. Now I am going to make Dr. Sareski the presenter. 1 second, please. Hello, Dr. Zareski, are you there? You are muted, so make sure that you unmute yourself.
All right.
Perfect, we have you.
Everyone hear me now?
And yep, we hear you. So you just need to make sure you bring in your webcam so that we can see you and we see your presentation in full screen.
Very
Perfect.
good.
Yep.
All right. Hello, everyone.
You just need to put the presentation again in presentation mode. That one, yes. Perfect. Thank you,
Very
Dr. Zareski.
All right. Well, good evening, everyone. Thank you for hanging in there for my presentation. My cell number is listed there, so please feel free to call me with any, especially cornea-related issues or questions, but anything else that comes up, I'm always available. So I wanted to focus tonight on keratoconus. We are, I think, by far the biggest cross-linking practice in Montgomery County and maybe in DC as well. I'd like to share with you some of my experience with this disease, with cross-linking, and our recent experience with this. So I don't have any financial disclosures. Keratoconus is obviously a very, sorry about that, Caroline, I don't know if you can answer me, but on my screen, the edge of my slides are cut off. Is that true for you guys?
We see it
well?
perfectly. We see it fine. I see it fine.
All right, as long as you guys can see, then great.
Yes,
can you see my mouse?
Yeah, we see your mouse.
Okay,
yes.
very good. So keratoconus obviously is a very serious corneal disease, but with the advent of cross-linking and its FDA approval 4 years ago, it is a completely different ballgame. Historically, we would say, okay, well, give you glasses, try contact lenses. If it gets to that level, consider surgery like a corneal transplant. But now we have something that can stop progression and can do so very effectively. Because of that, whereas in the past, the diagnosis, frankly, wasn't that important, but now diagnosis, especially early, is so incredibly important. And it's fairly common. These numbers, 1 in 2,000 having keratoconus, this is the number that you'll see thrown around in textbooks and thrown about throughout the ophthalmic literature. I think that's way too low. This number from the Netherlands, 1 in 375 patients, is probably closer to it if you include cases of form-fluous keratoconus or patients with basically no visual symptoms, maybe 20/20 vision, but if you do a topography, you'll see it. I think a big reason for that is the biggest risk factor for this condition is eye rubbing. And with increasing ocular surface diseases, with increasing allergies, it's leading to more eye rubbing and henceforth more keratoconus. Ultimately, as I said before, early diagnosis is key because I'll put it like this: when we do cross-linking on a teenager, it is so rewarding because this is someone obviously with their entire life ahead of them who otherwise might be headed for a corneal transplant, might otherwise be significantly hindered in their schooling prospects and their job prospects. And to be able to lock this disease in when they are 2020, 2025, 2030, when they have not yet had the significant morbidity from this disease, it's really exciting. So things that in your office, especially if you don't have a corneal topographer, should get your attention. History of eye rubbing and allergies, as we talked about, are a major risk factor. Family history is very important. This is absolutely a disease that runs in families. I've done cross-linking on both parents and children and teenage children. And then things to look out in general, as we know, most young people should correct to 20/20 vision, and especially if you have history and and especially in the setting of high astigmatism, if they're no longer correcting to 20/20, if their best corrected visual acuity is decreasing, that should be a major red flag. Other things, so distortion of Myers, if you do have any kind of keratometer, classic scissoring reflex and retinoscopy. If you have an autorefractor, that can be very helpful. I find that whereas patients with regular astigmatism, the autorefractor oftentimes does a very excellent job. If anything, over predicts the amount of manifested astigmatism. In keratoconus, it tends to way overestimate, because essentially this is a disease with irregular astigmatism, and by trying to put a regular number to it, you're going to have a disconnect there, and that should certainly get your attention too. Because ultimately, when you have someone with end-stage keratoconus who's got central scarring and very thin cornea, it's not hard to make the diagnosis. You don't need a topographer. But with the advent of cross-linking, the reason why all of this is so important is you can catch patients early and keep this disease from progressing. We're going to talk a lot more in later slides about topography, but basically placido topography uses Myers, uses these circular light images imprinted on the cornea, and based on how close or far apart, just like a topographic map, the topographer gives you an assessment of corneal curvature. Normally, astigmatism should be the same on either side of the center point. So if it is irregular, so this is a classic schematic where it's steeper, it's greater inferiorly, or it's skewed. It's not straight up and down, it's at an oblique angle. That should that's in essence what I'm looking for. And again, we'll talk more about this in coming slides. So let's talk about cross-linking. There are 2 FDA-approved indications. That is keratoconus and corneal ectasia following refractive surgery. There are several other off-label indications, which I've had personal success with, and there have been at least case series describing in the literature. One is pellucid marginal degeneration. This is another ectasia. Ectasia is a broad term for any kind of disease where your cornea gets thinner and steeper over time, so it's progressive. Pellucid just has a different topographic appearance than keratoconus. It also tends to be a little bit older patients, but you have this classic crab claw appearance as in this top right image. In keratoconus, if you look at, and we'll look at this again in a few slides, the area of greatest thinning is at the same spot of the steepest point. In pellucid, on the other hand, the area of greatest thinning tends to be much lower. So in fact, with the corneal topography, the thickness actually might appear quite normal, except for the outer 2 or 3 millimeters, which might not even be captured in the topography because it's so far peripheral. But either way, pellucid marginal, even though it's not FDA approved, certainly there's strong evidence to do cross-linking in any patient with this condition who's progressing. Radiokeratotomy was a procedure where radiocorneal incisions nearly full thickness were made in order to flatten myopia. This was done before the advent of LASIK and PRK. Unfortunately, this procedure has proved to be an absolute disaster. As time has gone on, there's been patients tend to have increasing irregular astigmatism. They tend to have a lot of visual fluctuations through the day. They tend to have loss of best corrected visual acuity. And it can be a very difficult disease to treat without many options. Because of just the nature of these incisions and the instability they create, a lot of these patients tend to get visual fluctuations throughout the day. Cross-linking has been documented in case series to help stabilize the vision. Not necessarily get the patients out of glasses, but keep the vision stable throughout the day. Infectious keratitis, corneal ulcers, actually has some really exciting literature. This will never be our first line, but for a dense central infection, that has poor prognosis for any kind of visual recovery without further surgery, namely a PK or penetrating corneal transplant. Doing cross-linking can help kill all the microbes, especially if it's a deep infection like a fungal infection. That has had some very exciting outcomes in the literature that can very much stabilize the patient so that they can have a quiet eye and then much more successfully in the future undergo corneal transplantation. So the concept here is that cross-linking involves dripping a riboflavin, which is a B2 vitamin, into the cornea, and then shining an ultraviolet light on the cornea. The idea is the riboflavin is going to essentially cross-link or make added connections between the collagen and the cornea. Collagen is the dominant protein in the cornea that provides its structure. So the concept here is fairly simple. You essentially want to take a cornea that's unstable and at a molecular level, stabilize it. Keep it from continuously getting steeper and thinner. And as I said before, in all comers, it's more than 90% effective. And I honestly think it's more effective than those numbers. So let's go through the actual procedure, because inevitably you're going to see keratoconus patients in your office, and you're gonna bring up crossing, and they're gonna ask you what it's like to undergo this procedure. This isn't a procedure much like the pterygium surgery that Dr. Martinez was talking about that we do in our minor procedure rooms. Patients are there for about an hour and a half, but a lot of that time is spent just getting a drop every couple minutes. A lot of it is I think ends up being quite boring, whereas there's an understandable and expected amount of anxiety going into any kind of ocular procedure, especially while you're awake. I find that generally patients are underwhelmed when they leave our office. In other words, that the actual experience is not nearly as intense or anxiety provoking as they expect going in. So the first step is to remove the corneal epithelium. If you look at the literature, there's varieties of protocols in doing cross-linking, and there are absolutely protocols that skip this step with fairly good results. In my hands, I always do an epithelial removal. The reason for that is if you look at the data closely, either studies show a statistically significant benefit for doing epithelium off procedure, or they're the same, but even in the studies that are the same, there tends to be a slight advantage, even if not statistically significant, for removing the epithelium. So until I see larger studies that are more convincing, this is the way that I'm going to continue to do the procedure. After that, every 2 minutes for 30 minutes, the patient gets a drop of riboflavin. At that point, I sit the patient up. The riboflavin is colored yellow, so I'll actually look in the slit lamp at the anterior chamber and make sure that there is yellow flare, much like uveitis, but without the cells and with a yellow tint to make sure that the drops have absorbed. Once the yellow has absorbed, I'll check the corneal thickness. Removing the epithelium makes you 50 or 60 microns thinner. The average corneal thickness is about 540 microns. So generally, at the very least, our patients are in the low to mid 400s with keratoconus at this point. The protocol says that they need to be 400. And if they're not 400, we can thicken their cornea with basically some hypotonic, which means low ion concentration drops, also riboflavin containing, to thicken the cornea. And they work well. The 400 is admittedly arbitrary. It's not uncommon. I'll have someone in the low 300s, even high 200s, and then I will aggressively try to thicken them. But if there are 370s, 380s, I oftentimes will just proceed with the procedure, because I think there's some risk to having the patient continue to certainly lay there for extra drops in terms of infection prevention and so forth. So I think it's a balance. I almost never see any corneal edema the day after surgery, which I would expect if the light does penetrate too deeply and does affect the corneal endothelial cells. So I think that this 400 is something I wish we had better studies on, because I think even though it's the protocol and the standard of care is less important than oftentimes made out to be. And then the final step is to basically shine light on the cornea for 30 minutes. I do use an eyelid holder and eyelid speculum to keep the eyes open. Whenever, of course, the first step was creating a corneal abrasion. So whenever the burning starts, we give another drop of anesthetic, and works very well. It's very important for the patients to be comfortable throughout this procedure. Besides obviously wanting them to be comfortable for the sake of their comfort, if they are starting to get uncomfortable, every once in a while there's a patient who doesn't want to take a numbing and tries to fight through it. They're moving around. They're not going to have as good of a treatment with this light lined up directly centered on the cornea. So I'm very aggressive about doing everything I can to keep them comfortable. And then the last step is to put a bandage contact lens in, which I usually remove after a few days. So very important. The aim, and this is oftentimes when I go through the whole procedure with patients in my office, I'll swing back to this point. I'll oftentimes repeat this multiple times in a single patient visit. The aim of cross-linking is not to help them see better. It is to slow the disease progression. It is to stop this from getting worse, slow or hopefully halt the disease progression. Obviously, our number one goal for these patients is to get them to see better, but that's where new glasses, hard contact lenses come into play. This is not LASIK. This is not a refractive procedure. It has been well described that especially young patients do sometimes get a flattening effect. Some of them do gain a line or two of best corrected vision. But I don't make a big deal of this to patients, because I don't want them hanging their hat on this. I don't want them being hopeful, because this really isn't why we're doing that. Most patients with a certain level of keratoconus are still going to need glasses, are still going to need potentially their specialty contact lenses when we're done. Yeah, even if they get a line or two of vision, it's nice, but it doesn't change ultimately their need for these visual aids. And insurance, I'll just mention briefly. As of a couple years ago, generally no insurance is paid for this procedure, and that really limited care. As of now, basically all of the commercial insurances are covering cross-linking. And with that, the number of cases we've been able to do have just exploded in the last year and a half or so. And this just illustrates essentially that it's broadly covered, not only in Maryland, but across the United States. In terms of my post-op care, so I always see patients 1 or 2 days after. I'm really just making sure that they're recovering well in terms of the post-operative discomfort. Because of the corneal abrasion, it's very normal, especially the first day, to have a lot of burning, a lot of irritation, foreign body sensation. Occasionally, there's a patient who really has a hard time with it. And it's just miserable for a couple days. I always talk up the pain to patients afterwards, even knowing that most people will be fine with it, especially with the bandage contact lens in place. But I believe that how we interpret pain and discomfort, a lot of that has a mental component to it. So I say this to patients: look, if I told you, look, this afterwards is not going to hurt at all, and you're going to see just like you did after, well, then they're going to be terrified. But if they go into this experience knowing that, especially the night after, and then for a few days after, vision's going to be blurry, they're going to be light sensitive, they're not going to be able to work during that time, it just goes a lot smoother. Mental expectations are everything. I keep people on an antibiotic and steroid for the first week, really as long as the bandage contact lens is in. At about a week, I remove the bandage contact lens. I confirm that the epithelium has healed. I oftentimes at that point will switch them from usually prednisolone to a milder steroid, just to avoid intraocular pressure increase. In a month, I'll see them back. I'll check their pressure to make sure it hasn't gone up, check their vision, and then we'll make a plan. Are we going to do the second eye? If the second eye's been done, or if the second eye's stable, are we going to try new glasses? Are we going to try a contact lens evaluation? Usually I will get at about the 6-month mark after the second eye, I'll get a new corneal topography as essentially a new baseline. I find that the sweet spot for prescribing new glasses, and contacts for that matter, is about the 3-month mark. I find that even at a month, a good proportion of patients, their vision is not back to where it was before surgery, whereas almost uniformly at 3 months it is, and sometimes better. So oftentimes, for example, if one of you sends me a patient, we'll do the cross-linking. I'll see them the one day, 1 week, 1 month visit, and then about the 3-month mark, I'll have them come back and see you for an updated refraction to get their glasses. I usually like to see them at 6 months and then 12 months. If the topography is stable at 12 months compared to 6 months, then I'll follow them yearly just to make sure that it's not progressing. Cross-linking can be done again. It can be done a second time, and that's been described in the literature with good success. But as I've said before, usually that's not necessary. In terms of adverse events, so haze in the cornea is something that just about everyone gets. If you look at the literature, it's 75%. I don't think it's visually significant because most patients have it, and most patients have it throughout a year, even when their vision's returned and they're happy with the quality of their vision and the recovery of their vision. The corneal epithelial defect, really this is delayed healing as an adverse event. Dryness is a big part of this procedure in terms of the healing time. I advise everyone to use artificial tears post-procedure. Infectious corneal ulcers, infectious keratitis or corneal ulcers, knock on wood, something that has not happened to me yet for one of my cross-linking patients, but with how many cross-linking patients we're doing, the reality is that at some point it probably will happen, in infections, unfortunately, with any large removal of epithelium are a risk. So, but we're very aggressive about using betadine to kill any organisms on the surface of the eye. We, make sure that I have patients start antibiotics a day in advance, not because I honestly think it makes a difference in terms of infection or no infection, but because it makes sure they get their drops in advance so that they can use them immediately after surgery to reduce that risk of infection. Eye pain, blurred vision is again, reduced visual acuity is not really an adverse event, is so much as just an expectation. So I'd like to talk to you about our recent experience here for cross-linking. So between August and October, we performed the surgery on 35 patients. About 2/3 were men, and that's consistent with my clinical experience that keratoconus is more common in men than women. This second column gives you the averages and then minimum and maximum. So age, the average was 29 and the range was 15 to 52. The youngest patient I've ever cross-linked is 11. I have no reservations about doing cross-linking on teenagers and even pre-teenagers if it is classic keratoconus and topography, and especially if I'm seeing progression. The average visual acuity was 20/40, and this is best corrected visual acuity, with a minimum of 20/20 to a maximum of 2400. The average keratometry, the average mean keratometry was 51, ranged from 42.8 to 69, and the steepest keratometry average was 61, 48 to 87 was the range, and the pachymetry averaged about 440. I mentioned the average thickness was 540. So these are all consistent with where you would expect someone with keratoconus. Interesting to note, there was one patient here who was actually, their thinnest point was thicker than the average. If you look at the mean keratometry, there was one patient I did who was 42.8. That's well within the normal range. When we think about keratoconus, it's a relative change. So if someone starts out at a Ks of 38 or 39, and if they started out with a pachymetry of 600, then this might actually be a significant change. So it's all about where they start. So this is the first representative image. This is our Penacam or corneal topographer, which I love. The technology is absolutely amazing. And this is showing a classic keratoconus picture. So this is the curvature map. It's essentially showing how steep the cornea is, and each number here is the steepness at that point. The average steepness here, the K mean, is about 51. Again, normal being about 40 to 45, with a fair amount of variability on either end, still within the normal range. As you can see, the steepest point gets up to 63, and you can see a 61 right here. This is the pachymetry map. This is the thickness map, and as you can see, area of thinning corresponds to the area of steepening. Here and on the right side, there is an anterior elevation map and a posterior elevation map. Essentially what these do is they say if they look at the peripheral cornea and they fit a soccer ball or a basketball to that, how much of an elevation is there in the front and especially the back. The back is much more sensitive to detecting keratoconus. This is my schematic. Essentially, the blue shows it's supposed to be a perfect circle, a soccer ball. The red is a keratoconus cornea, and essentially, when your cornea gets thinner and steeper, you get an elevation right in the center on the back surface, going from here to here. And that elevation is what's measured in this map. So, for example, this person is 58 microns. Again, 1,000 microns in a millimeter. And that's, if you compare to the soccer ball, that's how much of an elevation. As a side note, for my LASIK patients, where one of my greatest goals is to rule out this condition, I look at this posterior. You're never gonna, obviously, if you see someone like this, it's a no-brainer that they shouldn't have LASIK, but their keratoconus is a huge spectrum, and there are many patients out there with a very mild form of this. They'll never know that they have it until they go in for their refractive surgery evaluation. Looking at a posterior elevation of, for example, maybe 15 to 20 microns absolutely gets my attention, especially if they, have some astigmatism, have some thinning. That's probably a person I'm going to say is not a good candidate for LASIK. So this map has a number of different uses. So I'm going to flip through a few representative cases. This is someone who's even a little bit steeper. The last one, the average keratometry was 41. This patient's 54. Same pattern here. Steepening, thinning in that area, posterior elevation. This person's up to 93 microns over the soccer ball. So this is an example from a teenager who I did cross-linking surgery on a couple weeks ago. Just to illustrate, again, typical pattern, and you see this at a very young age. Now, this is someone based on his age. He's always going to be in glasses, but I am hopeful that he does get a little bit of flattening and does get a little bit of a reduction of his glasses prescription. Now, part of why I had this image, remember this is his right eye, this is his left. Keratoconus is a bilateral, but oftentimes very asymmetric disease. I'm sure there's a relationship in terms of eye rubbing and disproportionately rubbing one eye over the other, but especially for someone who also does LASIK surgery, this is a pretty scary image because it is just about as normal as it gets. Maybe you could believe just looking at the colors, there's a little bit of relative inferior steepening, but just based on this, if both eyes look like this, you'd have to believe that they would be a good candidate for LASIK. So the left eye in this patient is certainly not someone that I'm going to cross-link. I'm going to follow this eye every 6 months because I think there's a very good chance that over time he does start to get some steepening and does start to get an appearance in the left eye just like the right. But as I said before, this really does illustrate the asymmetry that's possible in this disease. This is a patient who actually was best corrected vision of 2020. He had recently moved from California. He was 32 years old. He had this Penacam that I mentioned is really the gold standard for corneal topography. So he had printouts of corneal topographies in the past that actually had been recommended to undergo cross-linking in the past. So I looked at those and could clearly see that he was getting worse, slowly, but still getting worse. Even though he's 20/20, and that's not your classic keratoconus patient by any means, and his cornea looked perfect. I could not look at the slit lamp and tell that he had keratoconus, especially in this eye. But this is a patient that I'm really excited to do cross-linking on because I want to preserve his 20/20 vision forever. This is not a patient who's going to need an RGP or a scleral lens because he's generally pretty happy with his vision with his glasses. He's got a little bit of difficulty with nighttime driving, but generally does pretty well. Not enough. I offered the contact lens fitting to him, but wasn't interested. This is someone who, has, if I mentioned 90% at all comers stability, having a relatively mild form of the disease, your chance of stability is that much higher. The reverse end of the spectrum, whereas he was average steepness of 45, got up to 57. This is someone who I believe was best corrected 2400. The average steepness was 69 diopters, got up to 87. You can see just how steep it is. This is an anterior segment OCT of the same patient. You can see how thin it gets in the center. You can see that this patient is starting to get scarring, anterior scarring in the front part of the cornea, which is classic for keratoconus. When you start to have scarring and when your cornea gets this thin, the thickness here is down to 330 microns, there starts to be, in the literature, a little bit less of a role of, a little bit less of a role of keratoconus, because the thought is, well, it's already so bad, you're going to end up doing a corneal transplant. The key thing about this patient, they were 20/50 with a scleral lens and don't want a corneal transplant, which I respect completely. A corneal transplant has a lot of risk. A corneal transplant, while in certain cases, and we're going to talk about this in a minute, is really the only option for visual recovery. It is a lifelong risk. You can have a lifelong risk of rejection, the body's immune system attacking the transplant, a lifelong risk of infection, the lifelong risk of the transplant failing. If you take someone who's 20 years old and do a transplant, the transplant might last 25 or 30 years, and that's a great duration, but then they need more surgery at 45 or 50, and each subsequent surgery carries with it more risk. So a penetrating keratoplasty or corneal transplant is a great operation, but if someone is 20/50 with a contact lens, the other eye is admittedly carrying the load, but they're generally happy with things, I'm not going to push a transplant. Instead, we do cross-linking. And this is someone who we performed cross-linking on about 3 weeks ago. She's doing very well. She's healing up excellently, and I'm excited for her to get refit in contact lenses afterwards, and hopefully never need a transplant. So remember this image. This is again the same patient that I flip back and forth. Remember the scarring or the kind of the white opacity in the front part of the eye versus this patient. So this is a patient that 2 or 3 months ago I did do a transplant on. I don't have her regular topography, but it was that much steeper, and the difference was she had that much more scarring. In general, for these patients, I still send them for a contact lens evaluation. I just want them to exhaust their options. I want them to feel like they're not being pushed to surgery and that they've exhausted everything. But this is someone who we tried that on, and even though is not actually as thin as the last patient, only gets to is actually about the same, about 320, but still she just had too much scarring and didn't do well with the contact lenses. So this is what she looked like about 2 months after, actually about 6 weeks. I was very excited. She was already seeing 20/50, oftentimes without glasses, oftentimes after a transplant, because you only have so much control over residual myopia and astigmatism. Oftentimes people at least need stronger glasses than a normal eye by all means, and oftentimes still need a hard contact lens. By 6 weeks out, the edema had essentially cleared. You can see this slit lamp optical section picture, and she looks great. I usually wait at least 4 months or so, and certainly until the swelling is cleared. Then I start to get serial topography as I look at where the astigmatism is. I look at their glasses prescription, and I start to remove sutures. Otherwise, I like to think that our practice at Visionary Eye Doctors can provide the complete keratoconus care. We also have 2 optometrists, Dr. Husseini and Dr. Saeed, with a lot of experience in fitting hard contact lenses. They have experience not only with RGP lenses, but piggyback lenses, scleral lenses. So if that's something that when you refer us a patient, if you are not comfortable with and you would like us to take over, we certainly can. As I said before, it is a priority of mine to make sure that the patient gets back to you for a refraction after their cross-linking, and for continued glasses check, and the contact lenses if that ends up being an option. Certainly we've been in the past few minutes talking about advanced cases, but a lot of these patients do great with soft toric lenses, especially after cross-linking, where the disease no longer keeps progressing. So for any patients you send me, I always encourage people to, our local referring doctors, to provide them with written documentation. Letters are great, but if the patient, if you send the letter to us before the patient actually makes the appointment, they might not have an account and the letter might not have anywhere to go. So I think it's always better to give the patient even just a written slip of paper with your findings, especially if, letting you know if you would like to take the reins on specialty contact lens fittings after cross-linking. I enjoy already many of you working as a team to take care of these patients who I'm very excited that more and more exciting options are available to them. So a few conclusions here, what we've already touched on, that, essentially I think the take home is that no longer is this a disease where, yeah, they probably have keratoconus, but they're not at a transplant level, so we'll just, keep trying glasses, maybe contacts. Cross-linking is an absolute game changer. It is hugely successful. It's very, very safe. I would have no reservations about recommending cross-linking on a family member or a friend. We look forward to sharing more patients with you as the time goes on. And thank you so much for your continued referrals and support. With that, happy to take any questions. And again, here's my cell phone number. Please reach out to me with any questions or concerns moving forward. Thank you.
Thank you so much, Dr. Saretsky. Wonderful presentation. You've definitely become an expert in cornea cross-linking. We're really proud of that. Thank you. Thank you so much. Okay, so now, 1 second, please. Okay, thank you, Dr. Saretsky. So I am going to go ahead and make me the presenter, and we are done for the evening, and I don't see any questions. Oh, actually, I do have one question for Dr. Saretsky. Cornea cross-linking price, Dr. Saretsky, what we're finding is that a lot of insurances are covering, right?
Yeah.
You want me to touch on that, or I'm really not so interested.
I'm happy to touch on it. So just to give you an idea of the kind of the fees or the what it takes to actually do the procedure. So a single, I'm not supposed to mention company names or anything like that, but a single company in the United States essentially has a monopoly on the materials that we use for cross-linking. So it is a very narrow market, and because of that, essentially every patient that we do cross-linking on, we have to write them a check for $3,000. And that's not including how much we paid for the machine, the equipment, the office supplies, the fact that this is an hour-and-a-half procedure. So each procedure does take a long time. This is not our 5-10 minute cataract surgery or LASIK surgery. So we're very much limited to how many patients can be scheduled in a single day. So it is an expensive procedure to perform, and for that, unfortunately, if insurance doesn't cover it, it is expensive for patients. The great news is that the commercial insurances have almost uniformly been covering this procedure. It's still not something that we make money on, but it's something that at least we're not losing money like we were months ago, years ago, when I first started doing this procedure at Visionary. So I don't have the exact figures for what our self-pay patients, if that's what the question was referring to, or for what our Medicaid patients have to pay out of pocket, but there are a series of programs which can assist these patients. There's something called the ARCH Foundation, which we've been using more and more, and basically the patients have to show documentation of income and documentation of financial resources to see if they qualify, and if they can, basically we waive all added fees for our office, and they get the drops from the company for free. So and I'm hopeful that the Medicaid insurances do come around, and that this procedure will be available to everyone in the coming year or two.
Got it. Perfect. Thank you, Dr. Sereski. That will be all for questions. And thank you very much for, oh, actually, never mind. I did see something else. Please forgive me. If a patient has dry eye, are there different outcomes post-op with cross-linking? One second. Any
Yes.
recommendation for those patients?
Yes, so that is a great question. By definition, anyone with keratoconus, their ocular surface is hypersensitive, whether that be allergies, whether that be dryness. There is usually something on their ocular surface that's driving them to rub their eyes. So in general, I find a higher incidence of dryness in my cross-linking patients, period. But that being said, after any kind of, frankly, any kind of surgery in the eye, even cataract surgery, I find that patients tend to have an increase in dryness, especially this time of year. Sorry about that. My kids are wondering where I've been for the last 2 hours, but I find that any type of ocular surface procedure, there is an increased incidence of dryness after. I'm fairly aggressive about managing that. I try to kind of anticipate dryness. So certainly if I see dryness preoperatively, I'll give them extra kind of advanced instructions and so forth. But in everyone, we recommend artificial tears every couple hours for the initial healing time. And I find that that just makes people more comfortable. It gets their epithelium to heal faster. All the above. It makes their vision recover. I saw a patient today. She was about a month out and from cross-linking. Her cornea looked great, but she had confluent SPK in the surface. That's not uncommon to see for someone who recently had a large corneal abrasion and probably has pre-existing dryness. So that's someone who really aggressive artificial tears. I believe in punctal plugs quite a bit, and oftentimes we'll offer that to patients. I'll try Restasis or Xiidra, and there's, you know, from Dr. Kremer's lecture, there's a whole host of other things that we can offer patients for healing. But
Okay.
That's an excellent question, because that is absolutely, especially in this patient population, especially with this type of procedure, it's certainly something that we get concerned about.
Great. If you don't mind, we're going to move along to another one. Do you go by the FDA cross-linking protocol, or do you do any of the labels as others do?
Oh, what was the last part? Do I go by the FDA, and do
you go by the FDA linking protocol, or do you do any off-label as others do?
Yes, so I do some off-label in terms of the conditions I treat. So as I mentioned before, keratoconus and post-LASIK ectasia or post-refractive surgery ectasia are the only 2 FDA-approved indications. I will do patients with pellucid marginal. I'll do patients with post-RK visual fluctuations, and as well as infectious keratitis. So I have no problem treating patients off-label if I believe it's clinically appropriate and there's good support in the literature. In terms of the protocol, so the protocol I use is called the Dresden protocol. It's named after Dresden, Germany, because that's where it was developed, because while the FDA took almost 15 years to approve cross-linking, it was much more readily available internationally, especially in Europe. And the well-defined protocol in terms of epithelium off, the amount of the concentration of the drops going in every 2 minutes for 30 minutes, the intensity of the ultraviolet light and for how long, that was all based on this Dresden protocol. So I generally follow that fairly closely. Where I deviate from it is in terms of the thickness, because, you know, you saw some of the patients, if they're 330 microns preoperatively and my target's 400, and then I remove the epithelium 50 or 60, so then they get down to 280 or 270, no matter how much thickening drops I use, they're just not going to get to 400. And it's just, I still do every effort to thicken them up, and oftentimes I can get them to 350, 360, even 370, but I'm not going to, you know, add an extra half an hour in the procedure to keep thickening them for what I consider just not a clinically significant benefit. And I do believe if the protocols were done with much larger studies and they looked at, you know, target of 400 and a target of 350, and they had, you know, hundreds of patients for each one, I think that they would show that there's no difference in outcomes, and there's even no difference in, you know, post-op day 1 corneal edema. But So essentially, I do follow the FDA-approved protocol, but I do tweak it a little bit for individual patients on what I think is clinically most important.
Very good. Do you prefer epi on or epi off?
Yeah, so I only do epi off. I always remove the epithelium. The reason for that is I would love to do epi on. Epi on is so much better for the patients because you don't have to make this corneal abrasion. They can go back to work the next day. They don't have the postoperative pain. Their vision recovers much faster. I would love to do epi on. I've been underwhelmed by the research looking at epi off. There's been a number of fairly large studies. Most of them show, some of them do show a statistically significant benefit for epi off. That's removing the epithelium. That's the way I do it. A lot of them show no difference, a statistically insignificant difference. But a lot of them, if you look closely at the numbers, there is a slight trend towards epi off being better, and especially in more long-lasting stabilization of the disease. So because of that, even though it's a harder recovery, I think that epi off is the way to go. But as I said before, I would love to switch my protocol. I would love to do it differently in a way that makes patients heal faster. I just need to see the data to convince me that that's the right way to go.
Okay, very good. I think I have something for Dr. Yeah, we will be getting the slides. Yeah, that's it for questions. Thank you very much, Dr. Soreski, for your presentation. I am going to now switch to my camera again. And thank you. Okay, so I have the two winners of the wine. We did say you guys get a lot of invitations all the time, so we wanted to make sure that we also give you some wine for the upcoming holidays. So I have the names right here. Give me 1 second. So the winners actually will get 6 bottles total, 3 of red, 3 of white, and I will contact you to coordinate the delivery. So Dr. 1 is actually Dr. Anthony Gonzalez, and Dr. 2 is actually Dr. Sita Razbani. So congratulations, Dr. Gonzalez and Dr. Razbani. I will contact you to deliver. Thank you so much all for participating in Visionary Eye Doctors lecture series. We want to do more of this, and as a matter of fact, we will already announce that we will do one in January. We're wishing everybody happy holidays. I am not sure if Dr. Martinez will want to come in and say goodbye, but I think that we are done for the night because it is already 8:08. Thank you, everybody. Have a great evening.
Thank you, everybody, for attending. I don't need to say anything else. Congratulations and thank you.